advisory board from 23 to 25, is that right? Member of the Lipoedema Australia. She offers a range of therapeutic techniques in her clinic, including manual lymphatic drainage, low-level laser and red light therapy, taking pneumatic compression pumps, TEO, fascial cupping and compression. Thank you. I've just broken the system, so... Sorry.
It's okay. I'll cry about it. Sorry.
Good morning. I'm on the board of Lipoedema Australia and have been on the advisory board, but today I'm talking solely as a remedial massage therapist in this field of lipoedema management. And I want to highlight how conflicting international guidelines create a daily practice variation for us as Australian remedial massage therapists. Across Australia, we remedial massage therapists are trying to help people with lipoedema, but many of us are doing so while navigating conflicting guidance about what the condition is, how it progresses, and what treatment is meant to achieve. I'll examine 4 key documents, reveal the dilemmas they create, and propose an ALA path forward. Why therapists are confused? There's lots of reasons. We face incompatible messages from global guidelines with differences in definition, progression, and treatment. We can't even agree on the incidence, with numbers floating anywhere between 10 to 19% of the female population. Yesterday, Vaughan mentioned 6% in the British system. Imagine counselling one client that MLD reduces edema, while telling another it's purely for pain modulation. This erodes our confidence and fragments care pathways. These conflicts hit hardest here in Australia, where referrals are surging, but standardised training lags. Without agreed upon facts, RMTs are giving conflicting advice to their clients based on the conflicting advice of the recognised consensus documents. We're not confused because we are undertrained. We are confused because the documents we're told to trust do not agree. The 4 guideline lenses. Here are the 4 guidelines I'm focusing on in my talk today. Firstly, the Wounds UK Best Practice from 2017. And this is an old document, but I include it because it was the first document of its kind that I became aware of, and it informed my own practice initially. Then came the JWC European Consensus in 2020, which was presented by Tobias Birch here at the ALA conference in 2022. Then came the US Standard of Care in 21, which feels like a bit of a response to the 2020 paper. And Germany's S2K guidelines came in 2024. Each shapes our practice differently. You can see from a quick glance, there are many similarities in the documents, especially the focus on symptom management. In January of this year, the Lipoedema World Alliance Delphi was published with 59 agreed upon statements. I feel this document will bring much clarity moving forward, but it was published after I submitted this application, and so I won't be talking about that today, but I do encourage you to read it. It's a very useful document. My aim today is not to declare one document the winner, but to show how different frameworks create different clinical behaviours. Where they conflict. There is a fundamental disagreement between the papers. Is lymphoedema an edema-free fat disorder, as the JWC 2020 consensus document asserts? Or is there lymphatic involvement, as the UK and US framework suggests, and the S2K paper says is a possibility? Do we use pain as a diagnostic criteria? It's mandatory in the German papers and optional elsewhere. Which parts of the body are affected? Germany says just the limbs, but not hands and feet. The US says the whole body can be affected. This means wildly different client prognoses. One framework offers hope through lifestyle. The other frames it as a progressive disease regardless. How do we communicate these two very different progression outlooks as remedial massage therapists? Is it one or the other, or a combination? These 4 documents describe the same condition through very different clinical lenses. And that changes what a remedial massage therapist thinks they are treating. When the rationale changes, the treatment explanation changes. And when the explanation changes, patient expectations change. What this means for us as remedial massage therapists. If there is no edema, as the 2020 paper suggests, then what role do we as remedial massage therapists have to play? In this scenario, none. We face a dilemma. How do we explain to new clients who have read that there is no edema in lymphoedema, and therefore MLD is irrelevant, that in fact there may be benefit? The hands-on experience I've had in clinic suggests that while lymphedema is not present in most cases, there is certainly a dynamic form of edema occurring in many women with lymphedema, in that limbs feel heavier and bigger at the end of the day, and that MLD and compression helps to modulate that fluid that's built up. And pain as a diagnostic. I find it an incredibly difficult thing to get a woman to recognize that she actually has pain, unless it is acute. It's sometimes necessary to cite examples of what chronic pain can look like. Example, finding remedial massage on the legs unbearable, or the taking of blood pressure requiring painkillers beforehand. These women think achy legs are normal, and they don't recognize that as pain. Therefore, getting someone to commit to wearing compression to manage pain when they don't recognize that they have it can be difficult, as opposed to telling someone that compression will help minimize the fluid that builds up throughout the day, as well as reducing the achy feeling that they get. This sometimes seems an easier sell. There are other inconsistencies, such as weight management and its impact, with the German papers expecting meaningful limb volume reduction through diet and exercise, but the US guidelines say it's largely ineffective on lymphoedema adipose tissue. Both recommend weight management, but for different reasons. And while these don't directly inform how we as remedial massage therapists work, they do form part of the conversation that we have in clinic. The same goes for the liposuction conversation. The European consensus says it's only after conservative failure. The US says it's disease modifying and should be part of the conversation earlier on. If we can't find some sort of agreement in Australia, then remedial massage therapists are completely undermined in how we treat. We play a huge role in the ongoing care of women with lymphedema, and we can take the pressure off overburdened public health facilities, but we're not being given a clear directive. This is where the lack of consensus becomes an ethical communication issue, not just a technical one. And the different guideline models create very different hands-on goals for remedial massage therapists. And why does this inconsistency matter? Practice variation means inconsistent outcomes, eroded therapist confidence, and confused clients navigating Instagram surgeons versus conservative therapies. Amid rising Australian advocacy, we risk suboptimal care when referrals hit our doors. We've standardized lymphedema protocols, though yesterday we freaked out that we don't quite know whether to say chronic edema or lymphedema. So maybe we haven't. It's time. Lymphoedema is demanding that same urgency of coming up with a standardized protocol. For remedial massage therapists, the challenge is not only what hands to use, but what words to use. Clinical uncertainty is manageable. Inconsistent communication is the bigger risk. And what Australia can do next? I propose ALA leadership. Let's position Australia as lymphoedema leaders. Let's collaborate post-presentation to scope this. We do not need universal agreement on every theory before we can agree on clearer communication, safer claims, and more consistent care. I suggest we start an ALA-supported national clinical dialogue, that we bring together the therapists who work in this industry, as well as the lived experience voices and the researchers, so that we're all talking from all angles. Identify the minimum areas of agreement from conservative care, and use some sort of process, whether it's a workshop, a Delphi, or a position statement, to create an Australasian practice framework. My call today is simple. Let's not leave therapists to interpret lymphoedema in isolation. Let's use the ALA to begin an Australasian consensus process that gives clinicians clearer guidance, gives patients more consistent care, and gives lymphoedema the clinical seriousness it deserves. Thank you for your attention. I value your experiences. Come talk to me at this time.
One from Lisa.